Here are the medical conditions that I will be covering, just setting for you. These are the medical conditions that are listed on the NCCPA blueprint, as well as the PAEA end of rotation exam list that they have. Lecture objectives, you can read these on your own. Pretty much the same, probably the majority of your clinical, or should be the majority of your clinical medicine lectures. Etiology, pathophysiology, which you can kind of put those together. Obviously, clinical presentation, how we work it up, treatment plan, complications, and prognosis. And those are also in line with what's listed in your syllabi that Dr. Latessa provided for you. Basic anatomy, again, I always put this in my lecture, but I never go over it with you because I don't want to bore you to tears. I know you've already had anatomy, but I just want to reiterate, it's extremely important that you understand the anatomy. Specifically for pituitary, because of some of the conditions that happen, one being an adenoma or a tumor in the pituitary gland, it puts pressure on certain things that can cause certain symptoms. So it's important to know where it's at, what the blood supply is, what secretes what. That's just the blood supply, its relation. The pituitary gland in relation to the optic chiasm. It's really important that you understand that. There's a couple of slides that explain that, why that is. It's just MRI. So you have the sagittal view. Image A is basically pre-contrast. Image B is post-contrast. And it just shows you how the difference in the uptake of the contrast, so you can get a better appreciation of where it's located. That's a normal pituitary. But it's so small, you wouldn't think it can do as much damage as it can do if it's not functioning properly, but it can. And again, these are not test question type things, these are just for you to know. I would know, not only for your probably physiology lecture, but definitely know what hormones are secreted from which lobe. From the anterior, please know that, and then also from the posterior. Which is kind of cool because posterior there's only two, so you got those two, you feel like pretty good on the rest. Please know those. There could potentially be a question regarding that. Do you have any specific questions about the hormones that are released? I know, again, this is not your physiology lecture, but if you do, just yell it out. I've actually listed them out for you, so you can just take a look at those. And again, the important thing about the endocrine course in general, and I said this last year, I taught the endocrinology course last year, is that it's all about that axis, the axis of hypothalamus to whatever, whether it's the thyroid or it's the pituitary gland or it's the, whatever, and then the end target organ where you're trying to go. And endocrinology in a nutshell is basically either you're secreting too much or you're not secreting enough, right? Essentially. So, in my opinion, endocrinology or the endocrine course is so important in regard to understanding what is being secreted enough or deficient and what lab helps you determine that. There's a lot of lab med in endocrinology or endocrinology workup. So you have to know what potentially is not being secreted or too much of it. This is in relation to or specific to the pituitary axis. But honestly, you need to know these. Okay, Any questions so far? It's pretty straightforward junk. The first thing that we're going to discuss is acromegaly. It's a very odd disorder. Does anybody, by show of hands, know someone or been around somebody with acromegaly that you know of? Thought maybe they had acromegaly? That's the interesting thing. You'll take this course and then you'll be like, I'm thinking back, I think that person probably had acromegaly. Anybody? Okay. Before I got into PA school, I worked for a hospice organization, and we had a gentleman in our service that had acromegaly. Very odd looking individual.
Actually, now that I read the symptom of gigantism, definitely, yeah.
Really?
Yeah, one of the players on my team, his father definitely had like really big nose, big ears,
Yeah,
and yeah, big hands and feet.
probably so then. Yeah.
Yeah.
Okay, basic definition, it's a rare, and it is rare for the most part. It's not like your thyroid where everybody and their brother has hypothyroidism. It's a rare endocrinologic disease characterized by excessive secretion of growth hormone, resulting in a syndrome of coarsened facial features and overgrowth of their hands and their feet. And those are like the three big things. Of course, there's a lot of other little signs and symptoms, but that's the big one. They have these very coarse facial features, and actually, in your boards, I had a board question, they will actually use the word coarse facial features. Why, I don't know, because I'm like, coarse, I think of rough, but anyway. Hands and feet, those are the three big things you need to understand in regard to the physical exam findings. Giantism is listed, but the only thing I'm going to touch on in regard to giantism is basically what it says right there. If they secrete excessive growth hormone before fusion of epiphyseal growth plates, that's referred to giantism. Afterwards, it's acromegaly. That's all you need to know in regard to the definition or the differentiation between those two in regard to this lecture. Does everybody understand that? Okay, awesome. Acromegaly is usually a later in life type thing. The average age is 40 to 45 years of age. It's kind of your time period that you would see this come about. And usually it takes several years, 7 to 10 years before the diagnosis is actually made. Because again, some of the complications or things that you see with this disease can just be missed, overlooked, put off onto other things as the cause. Now, once you get to those features of acromegaly, you're like, wow, yeah, that's definitely acromegaly. And I'll give you some pictures here. Male to female ratio is equal. You may see that different in literature, across literature, but it is a usual equal ratio to it. The gentleman, the guy we had was a male that was on the hospice service. So etiology, pathophysiology of it, it's excessive secretion, so too much growth hormone, stimulates the liver to secrete insulin-like growth factor 1, IGF-1, which causes most of the condition's clinical features. Have you had in your physiology lecture these hormones? So these hormones are just not completely Greek to you right now, like IGF-1, growth hormone. You should have had, okay, awesome, good. You'll probably have to read up on them again, but I just want to make sure you understand what they are. Majority of individuals with acromegaly, you need to know this, it is secondary, caused by a adenoma of the pituitary gland, the anterior stalk or anterior lobe of it. So the main reason why most people show greater than 90% is a benign growth hormone secreting adenoma of the anterior pituitary. The other individuals, the remaining 10% or less, have ectopic growth hormone secreting tumor somewhere else in their body. And that's kind of honestly how it is for the most part endocrine, my opinion, is it's either a tumor in the actual organ, like the thyroid or pituitary or whatever secreting that causes an increase in it, or it's somewhere else in the body that's secreting it when you have too much. We're just looking here. The last two sentences of that last bullet are kind of listing out where those ectopic secretions may be coming from. So pancreatic, small cell lung cancer is a really funky one, if you remember that from your poem. It has all kinds of hormones that's released from it that causes all sorts of really odd symptoms. So they can have a growth hormone secreting tumor in their lung as well. Adrenal gland, thyroid cancer, and then a pheo can also secrete excessive growth hormone. But again, the take-home point from that slide is it's a benign growth hormone secreting pituitary adenoma. I didn't say it here out loud, it's actually below in the notes section of your slide. Also genetic, there's a lot of genetic issues. It's all typed out for you, by the way, so you don't have to sit there and do this. Also, etiology-wise, there's a genetic component to it. Individuals have certain familial genetic predisposition and they will have issues with it. So history is what the patient comes in and tells us. So this is their symptoms. Some of these words I know are really medical sounding. Of course, the patient wouldn't come in and say, yeah, I have galactorrhea. But they could come in and say, I have mental discharge or any one of these. Growth hormone, again, it's not physiology, but growth hormone is so many things to the human body. It's important. We just think of it as about getting big or getting too small, right? But it does a lot of other things. It affects every organ, muscular, neurovascular, a lot of our main organs, and we'll get to that bullet point in a minute. Also derm, growth hormone also affects our skin. So musculoskeletal, they get enlarging, shoe, and ring size. So this goes along with that hands and feet complaint. And they may come in saying, yeah, you know, my rings used to fit, now I can't even get them on my hands. Or my shoes used to fit over the last 6-7 months, they no longer go on my feet. So that may be something that they may complain about. Arthralgias, myalgias, they may come in complaining of soreness, achiness of the muscles. Neurologic complaints that they may have, headache, vision changes. I would absolutely know temporal hemianopsia. I'm going to draw this out for you. I memorized this when I was in anatomy. And I've never forgotten it, because if you'll memorize this, you'll... So this is the patient's right side. So this is temporal, right? This is nasal. Learn how to draw that. Anywhere a question puts a tumor, you'll be able to put the tumor there and follow the track up. So if it's there. Does that make sense? I memorized that anatomy, I've never forgotten it. It will help. So we'll get to it in a minute, but if it's a pituitary adenoma, and it's getting bigger and bigger and bigger, kind of like 5 slides earlier, what's it putting pressure on? Potentially, yes, absolutely. If you understand anatomically where the pituitary gland is and where that sits in relation to that. So where would the optic Hyson be on this? Right there, right? So if I read, pituitary adenoma, what's the deficit? It's going to give you 4 of them. It'll say binasal, hemianopsia, bitemporal, this is like a classic question. So if I know pituitary adenoma, I put it right there, right? And I just know what line it's touching. So it's touching that line, I'm going to draw it up, I'm going to mark that out. So bitemporal hemianopsia. Just always remember that. Absolutely, we will have that question on your exam. Know that, please. Vision changes. Hand numbness, carpal tunnel syndrome. That's because the growth hormone affects that nerve, the median nerve. I know you haven't had your own yet. They get that numbness, tingling feeling. Fatigue, weakness, they get a lot of sleep disturbances. Dermatologic, they get an increased sweating, and they develop an oily sheen to their skin. Endocrine, and again, not to get into all the different things that are being affected here, but a lot of the symptoms that you see here may be due to growth hormone excess, but it also may be due to excess of another hormone. Does that make sense? Because as in endocrinology, if one goes really up, it may decrease another one somewhere downstream. And I don't want you to focus too much on that. If you want to go later on, read why they would have a decreased libido, what hormone, you can probably kind of figure it out. You can go do that, but I wouldn't write a question that would be that specific to you. Just know the signs and symptoms of it. So again,